Welcome to Epilepsy Awareness Month and Epilepsy Awareness Day. It's unfortunate that we can't all be together as we had been at Disney, but hopefully next year. My name is Joe Sullivan. I'm a pediatric epileptologist at UCSF, and myself and my colleagues on both the pediatric and adult side, I know have volunteered to give a number of talks throughout the day today. And what I have chosen to speak about is basically just an update on clinical trials in pediatric epilepsy. This is meant to be informal. It's probably the formal comments here or slides are going to be maybe 15 minutes, and that leaves 15 minutes at the end for anyone to ask any questions. So let me get into presenter mode here. Here we go. So okay, so here's the brief outline. So I first want to go over the different types of clinical trials that are commonly done in epilepsy, and in particular pediatric epilepsy, an overview of what that means for an epilepsy clinical trial, to briefly touch on the risks and benefits of participating, and then again at the end leave it open for some questions. Sorry, I'm just going to go back here. Can't see my title because there we go. I had to put the video off to the side and couldn't see my mouse. So I believe that this is such an exciting time for pediatric epilepsy research. I mean, literally 6 or 7 years ago, there were only a handful of clinical trials that were focusing on children. But I think what really has been driving this is that now that we have more accessibility to genetic testing to try and arrive at a more precise diagnosis for many of our kids who have an epilepsy of to be determined or unknown cause, this is allowing a more specific genetic diagnosis. And then it goes without saying, if we know the underlying cause, then we can focus our efforts on how to best treat these individuals. And this has actually been shown in this actual paper that I was a co-author on with the Invitae group, which has really done a lot to move the field forward in terms of genetic testing, to look at what the possible precision medicine approaches are. As many of you know who have a child with epilepsy, it often can be a little bit embarrassing for us as clinicians because we kind of go through this sort of trial and error of trying different medications. And that trial and error really is an educated trial and error. I hope you believe that, because we are trying to choose medications based on the specific seizure types. Certainly if there's a specific genetic syndrome where we have experience of certain medications that work better than others, or maybe certain medications to stay away from. But what this expanding list of genetic diagnoses is really allowing for basic scientists, drug companies to then look at, if we know the underlying cause, how can we actually design or develop a specific therapy against that specific genetic condition. And so in this study that looked at almost 9,000 patients who actually had genetic testing done, and I really want to focus at the bottom C here, this figure. These are the genes that actually most commonly came up in these genetic panels. You can see at the far left, SCN1A, so the mutation, the variant that typically causes Gervais Syndrome was the most common. Then MECP2, so Rett syndrome. I'm not going to read through all of these, but these are sort of the most relevant epilepsy genes, I would say, in 2020. That doesn't mean if your child or loved one has a mutation that's not on this list, doesn't mean that it's not relevant, but it takes some sort of core number of patients to be found for there to, I think, garner more interest in terms of developing some of these precision medicine-based therapies. And so if you look at the color, then the ones that are in sort of the teal, those lines are the ones that, as of the time of this publication just a few years ago, were felt to have these PMI, so precision medicine indications, meaning like, okay, now that we have this specific diagnosis, I can look at that patient and how we approach their treatment in slightly a different way than I otherwise may have if in the absence of that information. This list, I would argue, or these colors, I would say, are rapidly changing in the sense that, like I'll call out CDKL5 here. So we had 38 variants that were found in this patient population, and at the time, this was considered green, so did not have precision medicine implications, but there has been a clinical trial that was recently completed of a compound called ganaxolone that showed efficacy in a patient population with CDKL5, and that company is going to be submitting for regulatory approval, and that's hopefully that will flip that color to teal. So hopefully if I give this talk 5 years for now, we'll see a larger list of genes and more of those colors that have flipped to teal with more precision medicine implications. And so with that backdrop, okay, so now we actually have maybe we know the why. Why does your child have epilepsy? And then there's a compound out there that has this precision medicine implication that it should hypothetically work for that individual patient. So why is a clinical trial necessary? Well, as you all know, if you've cared for someone who has seizures, these drugs are not without their own side effects. And certainly when there's a novel compound that has only been studied or has maybe not been studied in any human, or specifically has not been studied in a child, it's key that we want to understand that this drug is safe and well tolerated. We also, need to understand what types of dosing need to be used, right? We have a compound, again, that maybe in the basic science lab shows promise, but how does that translate into number of milligrams per kilogram, different ages? And so clinical trials actually allow us to look at these dose finding, to find an optimal dose, again, that is safe and well tolerated. And then ideally, right, what we all want is we want the drug to work. Right, so this is what we call efficacy. We want the drug to work for the intended outcome, which for the majority of epilepsy clinical trials are seizures, but stay tuned because I think that there's some more exciting work that is just being done in some clinical trials to start looking at some of the endpoints that are so important to us as clinicians and caregivers that are not all seizure related, that really do have an overall impact on quality of life. And then lastly, I know this is going to seem maybe the boring part, but the FDA does require these three things to happen so that they can approve the drug. They want to know that it's safe, that the doses are well validated, and they want to know that it works so that if it gets FDA approval, so that we then as clinicians can write the actual prescription. And so here are the different sort of phases of clinical trials that I think it's important to understand, because some of these are actually, some of these steps are potentially skipped, or not skipped, but can be combined, specifically when we're talking about some of these rare epilepsies that affect children. So usually, right, phase one is where they pay healthy adult volunteers to come into the hospital and get a medication at escalating doses. They check blood tests, they're checking EKGs, they're asking the patient how they feel, and they really just want to understand, okay, what is the highest dose that can be given and how is the body reacting, and are there any harmful side effects? And this is again done in usually adults, and usually adults that do not have the disease of interest. Then if that goes well and they show that there is a dosing range and they define what the side effects are, it moves on to a phase two. So now this is starting to look at, does it actually work for the intended purpose? So in epilepsy trials, does it help reduce seizures? And so these trials often, there can be a couple different ways they go. Sometimes it can just be an open label where they just, meaning you get the drug and we follow you and see if the seizures do improve. Sometimes they will throw in a placebo, which I'm going to get into here next, to see if compared to placebo, does the treatment work better? But really, this is trying to just get some preliminary signal that if we have a drug that is well tolerated and safe, does it actually start to work for seizures based on what we know about how it should work, maybe in some of these specific gene mutations. And then lastly, the phase 3 is really the gold standard for getting a drug brought to the clinic and brought to sort of FDA approval and market. And this is a randomized placebo-controlled trial. And so what these are is basically patients are recruited into the trial based on certain eligibility, and they are randomized to receive a placebo, which is an inactive substance that's supposed to be taste and smell exactly like the compound that's actually being studied. And then the other group gets randomized to the active compound. And usually the investigator or the clinician does not know what one is getting. The study team, the nurses, the study coordinators do not know, nor do the parents or the patient know. And so this allows us to try and eliminate any bias and really compare, again, still safety. We want to know about the side effects, but also we want to know if the efficacy in terms of how much do seizures improve in the treatment group compared to those that are receiving the placebo, or some people call it a sugar pill if it's a tablet. And then lastly, phase 4, after a drug gets approved, these trials often only go on for a year or two. So that exposure is long, right? A couple of years. But if these are drugs that patients are going to be taking for many years, we do still want to understand the longer term safety. And so those are what go into phase 4 clinical trials. And so when one is designing a clinical trial, it's important to define what we call the primary endpoint. So this is the main result. This is what we as clinicians, as investigators, this is what the companies are hanging their hat on, to say, I think that my drug should result in X, okay? And again, most of the time that is seizures. And then it gets a little bit tricky because many of you probably know who are listening, there are many different types of seizures. And the key here is that if we're gonna hang our hat on a seizure primary outcome, we have to make sure that that seizure is recognizable and countable, right? Because if it's not countable, you might as well just throw a bunch of darts on a dartboard and sort of say, okay, did the drug work or did it not? And so this is, I think, something we've been paying very close attention to as we start to define some of these genetic epilepsies, to look at the different types of seizures that occur and just state upfront, do we think that this can be reliably counted? If we don't think it can be reliably counted, then it shouldn't be included as a primary endpoint seizure, right? Because then you are really setting yourself up for accidental failure or accidental success because there's just too much variability there. So this still ends up being the primary endpoint for the majority of epilepsy treatment trials. But we do also care deeply about these other, what we call non-seizure related endpoints or comorbidities. So things that we know are very common in a group of patients who have a difficult to treat epilepsy. And so those are cognition, behavior, sleep, and maybe EEG findings, right? EEG, maybe we want to also see improvements in an EEG when a novel treatment is introduced. So many of you may be asking, why is a placebo necessary, right? I can count my kids' seizures. I'm going to give them the drug. Of course, I'm going to be honest and say that seizures, I had 2 seizures today and 1 seizure yesterday. But as it turns out, there is a lot of bias that goes into this. And I feel this as a clinician, anytime that I want to start a new drug, and this is not even a part of a clinical trial, we want it to work, right? We really want it to work for our patients. And so do moms and dads, and so do patients. And so inherent in that, maybe there's that, yes, you're going to be honest, but like, okay, was that a seizure? But if you're thinking you're on a drug and you really want it to work, maybe you just decide, not to check that. But if you don't know you're on the drug, that hopefully is all going to be adjusted for in the background when we look at these groups of patients. I will say that seizures are unpredictable. There have been many times in my own clinical practice where I want to start a medicine because seizures are increasing. And then the parent says, you know what, we're just not ready yet. Let's just give it a couple more weeks. And then lo and behold, seizures get better. And so if I would have started that drug, or a new drug or made a dose change, we would have said, oh, see, seizures were on the rise. We made a change, seizures got better, must have been the drug. When in fact, it's this roller coaster ride that all of our families are living, of the unpredictability of seizures. And so this is also why it's important to have a placebo. And I should have, if this was more interactive, I would have put this up and had people say, let's take guesses as to what the placebo response has been. And this has been pretty consistent over the last few decades in epilepsy drug trials, both in children and adults. And these numbers up here are from a review that looked at many of these trials. It's about 20%. So just enrolling in a clinical trial and being put on an inactive medication that is a placebo, has no active component that we would expect to have any impact on seizures. Seizures can improve by 20%, and then adults can improve by 10%. So in order for us to be confident that the active drug, or the active treatment, I should say, being studied is actually responsible for the improvement, we have to actually show that compared to this 20% plus or minus 2%, that the active treatment does better. Are there risks from a placebo? That may seem like a silly question, right? Well, it's an inactive medicine. Why would there be any risk? Well, it's an inactive medicine, so you are signing your child, your loved one, to participate in one of these trials, and they may be getting no additional treatment above and beyond what they're already getting for a 3-month period of time. And so there are risks to that, right? There's risks that presumably you're enrolling in a trial because you have ongoing seizures and we want to do better. And we know that ongoing seizures, especially in this treatment-resistant group, sadly does increase the risk of SUDEP. And in this study that was published about 10 years ago, they looked at the risk of SUDEP in clinical trials in those that were receiving the placebo arm versus those that were receiving the active arm. And you can see there is definitely an increased risk of SUDEP in those that are receiving placebo. Now, I hope this doesn't scare those of you away who are considering participating in a clinical trial, because this is the way that we do bring new treatments, new effective treatments into the clinic. But just to acknowledge that we as investigators take this seriously when we are recruiting patients for these clinical trials, and try to talk about these risks of being on placebo. Interestingly, there are some different trial designs that are being floated around specifically for patients who are having a very high seizure burden. So just as an example, some of these conditions, patients are having many seizures per day, right? So do you really need 12 weeks of a treatment to say whether or not it is effective or not? Probably not. You probably, depending on how the drug is absorbed and how quickly you can get it up to a therapeutic dose, you probably can make that decision after 4 weeks. And so there are some different trial designs that are being looked at that really allow each individual patient to have their sort of customized treatment and maintenance period based on how frequently their seizures are going into the randomization to different treatments. So then we get into change, right? So we're talking about seizures, we're talking about these other very important things like cognition and behavior. So we may all feel that there's an opportunity for change, but if it's there, it has to be measurable, right? It has to be more than just like, yeah, I think they're better. I think that they're more alert. I think that she's sleeping better. But that doesn't necessarily satisfy the sort of statistical rigor that we need for us to say, okay, this is a medication that we will use in the clinic. And so that's why these primary endpoints so often are focused on seizures, because even though seizures are difficult to count in some instances, they are, for the most part, countable, especially if there's a lot of training that goes in that, and it's a measurable endpoint. Some of these other issues, such as sleep and behavior, right? The changes are important, but maybe the changes are so small that it's difficult to measure over this short period of time. And these trials do have to end. Unfortunately, getting back to that placebo exposure, we certainly do not want to expose someone to a placebo longer than we have to. And so this is where these secondary endpoints are sort of put in there as exploratory, so that one, if it reduces seizures, that's important to get it into the clinic. And then two, if some of these secondary endpoints are exploratory, where we think it may help with sleep, those can be put in there so that they at least are attempting to move the needle there. And that's where I thank all of those who participate in these trials. They do take a lot of work and a lot of your time, but this is why we're putting in all these other extra pieces to try and see if there's an effect there. And then there are these holistic measures. I think that I don't want to minimize the sort of impression. I know that you know your children or know your loved one, and if you think they are so much better on this drug, again, in these trials, you're going to be blinded. You may not know if they're getting the medication or the placebo, but there's been an effort to just ask this simple question. It's called a clinical global impression of change. And it's just a scale of 1 to 7. You know, how do you feel your child is doing now compared to, before enrolling in the trial? And the number 4 is really they're the same. Number 1 is they're very much improved. Number 7 is they're very much worse. And we've actually looked in some of these trials and tried to see in those trials where a lot of the patients are very much improved, what is driving that? And that's a topic for a whole other talk. Here is basically a figure that tries to simplify what one of these phase 3 clinical trials looks like. Okay, so for the far left there in the sort of orange rectangle, you have the screening or baseline period where we're just trying to get a sense of like how frequent are seizures occurring during this baseline period. So that serves as the comparator, right? That we're going to compare frequency of seizures once the medication or the placebo is started. Then this randomization rectangle, that's where in a blinded fashion, you're given bottles of medication at a certain dose, yet we don't know if it's active or placebo. That dose is usually titrated, right? We don't want to start off on the highest dose right up front. So there's a dosage schedule that goes usually over a period of 2 to 4 weeks. And then things kind of sit tight for 12 weeks. And you come into the clinic, you get phone calls. We again want to be monitoring safety, tolerability, and want to make sure that we're counting the seizures and not missing any days. Because again, the success of the drug in terms of the unblinding at the end is going to depend on reliably counting that primary endpoint. Then at the end of the treatment period, patients are given the option to roll them over into what's called an open label extension, which there is when you are guaranteed actually to get the active drug component. Or if you do choose not to do that, then there's a taper off, and then you have a safety follow-up visit, and then you go back to your sort of routine clinical care with your provider. So the risks and benefits may seem obvious, but I just wanted to throw them up there. The benefits are certainly, if you're considering a clinical trial, that usually means that the conventional sort of therapies that are available to you have not been effective, and so this gives someone access to a novel therapy. And it also allows you and your child to be to be followed more closely. Now that could actually be also a con, right? You can see down in the risk. So you have to come into the clinic sometimes every 2 or 4 weeks for these study visits. But please know that's because we want to make sure that this investigational drug or investigational therapy is safe. And so some of the risks, there may certainly be a lot of anxiety surrounding the placebo exposure. Folks are well read and hear about this trial. And of course, they want to be in the trial so they get a chance to access this novel therapy. But for the reasons I've already presented, there is the need for this placebo. There is the more routine visits, travel, time off work. And then of course, as much as we know what the side effects are based on the phase 1, right, the one that was done in the healthy adult volunteers, kids are different. And so maybe there would be side effects that would be different in kids, or maybe there'll be new side effects that emerge. So the trials available, historically, most anti-seizure medications were studied in adults with focal onset seizures, and then later they were opened up to children. Rarely were these studied in specific syndromes. An example would be infantile spasms and ACTH. There have been a number of trials in Lennox-Gastaut syndrome, felbamate and clobazam are just some example. But I think in the last 5 years, this is where it's been exciting for me as a pediatric epilepsy specialist, because there's a whole host of trials that are opened up for specific syndromes. Certainly, Gervais syndrome is receiving a lot of attention. There have been 2 completed trials just in leading to new compound approvals of cannabidiol in 2018 and fenfluramine in 2020. There are at least 5 other trials that are ongoing or will be starting relatively soon. I highlighted here, sort of in the teal, the studies that we at UCSF are participating in. And then beyond Gervais syndrome, there are so many other genetic conditions where novel compounds are actually being looked at. I'm not going to read through all these, but just to show that this list 4 or 5 years ago just would have been a blank, essentially a blank slide. So getting back to the importance of genetic characterization to allow for the development of these precision medicine approaches, I think we really have the opportunity to move the field forward and ideally get your children to a better space. And again, the teal here, this is not meant to be promotional, but these are the studies that we at UCSF are participating in. So how do you find these trials? So certainly clinicaltrials.gov is the government website that lists all of these. Many of you are hopefully plugged into specific patient groups and foundations if you have one of these precise diagnoses, and there are many. But if it comes down to it, just ask your doctor. We generally are made aware of new trials that are out there. And if you hear of a trial, educate your doctor. Say, Doc, I heard that there's this new trial opening up, and ask if they would refer you for a possible consideration. So I do, just in my last slide, and I maybe it was a little bit long-winded here, but I do believe that we are in the beginning of a new era with more trials available to pediatric patients than ever before, that this is going to lead to more precision-based approaches. And I really just want to thank you all, because this is not possible without you entrusting the safety and well-being of your child or family member with us as the clinicians and investigators, as we partner with industries who are trying to bring these new compounds to market.